So as we joining, I want to appreciate everyone, every country. It's like we are going to take in on HIV prevention, specifically on the pillar of the KP programming. We understand in this funding cut, every country is actually relying on its own strategies and modalities and how they are going to approach the situations we are having and how we are going to do it. So we are appreciating most of the countries are struggling in their own way, but we are making a huge milestone. And with what we had during the learning and session during the SSLN period and others. So we do appreciate that. So I want to also as an introduction, just to appreciate everyone who has been in KP programming. I've been in South Sudan. So I hope the South Sudan team is on this call. And we know everyone is struggling in terms of putting the KP programming in the larger portfolio under the MOHO, the facility. So one of the country I visited, and that is one of the points that we need to learn and how they're supposed to go about it for sustainability aspect, is how do we integrate these programs now within our facilities so they can be accessible, because KP programming being accessible is being a really challenge. And there are countries who have done better. At least some of the facilities actually were able to integrate, that's including Kenya and Tanzania is one of the countries which has have able to be integrating these services. And the Uganda, Malawi will be telling us how what was possible and what should we learn, how can we improve, where should we improve, where do we start. So we are hoping this session will be interacting sessions. So we really appreciate that we are able to join in. We are expecting contributing from all the countries which are joining in, taking in on will be our sessions for today. And I think we are done with the first session. So we'll be taking in Uganda as the first country to present on the integration experience. How does it look like? What has been done, the principles, success, and challenges. So other countries will learn and see how do we improve. This is our programs, and we appreciate that they'll be able to present that. When you look at Uganda and all the process, all the bottlenecks they were facing, still they were able to do so. So it's something we need to learn from Uganda. So I welcome you all and appreciate everyone who was able to join. Because of their time limit, kindly register your name on the chat box, your country, your organization. So we welcome Uganda. Geraldine Pande will be taking us through our presentation for today from MOH Uganda, and therefore McLean Kionga for the community aspect. So over to you, Uganda, for 20 minutes presentation. Then we'll be having the Q&A Q&A session for the members to take in. You are welcome. Gerard Pande, over to you.
Yes, thank you for the kind introduction. I'm presenting on behalf of Uganda, and I work for the Ministry of Health as a program person coordinating KPSTI programming. Just as a background for you to understand the HIV burden in Uganda and among the population, it's true that as a country, KP still face a lot of stigma and discrimination, and this is most likely to lead them to be left behind. You know that as a country in 2023, around May, we assented to the anti-homosexual law, which created a lot of stigma and discrimination. The HIV prevalence, you know, every after 5 years, we do a population-based survey. The last one was done in 2022, and we are preparing to do another one with funds from PEPFAR, and the general HIV prevalence is 5.1. Now, when you compare among the key population, for example, sex workers ranges, the average is 33%, but in some of the towns and cities, it goes to 50%. Then among the transgender, around 16%, men who have sex with men, 13%. And then the incarcerated, around 15%, and the PUIDs around 15 to 20%. This HIV prevalence is way high than the general population. Next slide. Next slide. So sorry, you are moving so fast. Go back. Go back. Next slide. Next slide. Yeah, that one. The integration process. If you've moved again, yes, that. I don't know why you are moving so fast. There's the slide before that.
Okay, slide number 7, I think you can capture that.
Yes, that one. So the integration process and principles, the selection of facilities to integrate KP programming service is guided by mapping and profiling and location where KPs mainly congregate. These are hotspot areas. The mapping is done to identify these locations, and the size of the population is estimated. We also identify the facilities which are closer to those locations. And the exercise has helped us to set targets for these facilities which are closer to those locations. Next slide. Next slide. Yes. So after our mapping, we've done a mapping, and these are the facilities that we have identified. And when you look at this slide, they are majorly around the major highways and the border districts. And most of them have regional referral hospitals, and some have health center force and general hospitals. Next slide. Next slide. Yes, so as ministry, we came up with guidelines for establishing facilities, and these facilities are called drop-in centers, and we both have the community and facility drop-in centers. But for this presentation, I'm presenting the facility drop-in centers, the facilities that provide services to the KPs and they are within the public facilities. Next slide. And basically the rationale for us to open up such programs in public facilities is to increase access, quality tailored comprehensive services to our KPs, to empower communities to participate in health, because in these facilities, we also have peers, but also to build the capacity of the communities and other stakeholders, advocate for HIV, sexual and reproductive health services, and eliminate GBV. And first, implementation of research, because when we do implementation research in public facilities, it is easier. So we also do research. That's the rationale for integrating KP programming within the public facilities. Next slide. We provide a package of services to this, and I would break the package into biomedical package, which include PrEP, circumcision, treatment and care, STI screening, then the behavior, which include risk reduction, counseling, demand creation, and when we are doing this, we also address structural issues like stigma and discrimination to just create an enabling environment for KPs to access services. Next slide. And the model we use to provide services, we provide services both at facility, but we extend services to the community where we do either outreaches or we do it in the drop-in center, the community drop-in center. And in all these, we use our peers. So you find peers attached to the public facilities, but they are also helping their mobilization within the communities where they live. Next slide. So, staffing at the health facility DICs. So integrating of key population services within the government facilities needs investment in setting up a team, which includes both the clinical team, which provides services at the facility, but they also extend the outreach services. And the team at this facility includes the clinician, the pharmacist, the lab, the nurse, and these are either supported by government or by IPs. And these extend the outreaches to the communities, and the same team comprising of the clinician, the nurse, they go out to the community either to do outreaches, or in the community DICs provide services. We also have the monitoring and evaluation team in these facility-based DICs, just to help in entering of the data, but also to do monitoring and evaluation. Next slide. In each of these facilities, we also have a coordinator at the facility who coordinates the KP activities. It is critical to provide services, and when you are providing services, the team has to be, you have to build the capacity of the service provider and do mentorship. And in capacity building, just to enable them to provide services which are free of stigma and discrimination. And you do this to both the outreach team and also the health service, the facility team. You build their capacity. And we've done this, we've got a training manual. We train health workers for 5 days to just equip them with the basics, their roles and responsibilities, and why they need to provide services to the KPs. And we do this for both the outreach workers, but also the health workers at the facility. Next slide. Next slide. These are some of the documents. We have a training manual for the peers. So we also train the peers, but also train the health workers. Now, when we assented to the homosexual law, in May 2023, we came up with the guidelines for safety and security, just provide the services, but make sure that as we provide services, one, we protect the service provider, we protect the people who receive services, we also protect the data which is collected, but also protect the places that provide services to the KPs. So basically, those are some of the training materials that have enables us to provide KP-friendly services. Next slide. So key considerations that have made this program a success: identifying the right facilities for integration is very critical, and the clinics should be located near where KPs always congregate, those hotspot areas. Capacity building to make sure that the staff that are providing services are trained, and this is cuts across all cadres, including people in the records, including even if it is possible, you also include the other counselors, the askaris, train them. Ownership of the program has been critical, where you have to identify a few peers who work within the community, such that these services which are provided are also peer-led. Then advocacy and sensitization through engagements with the relevant stakeholders around the facility and within the district is so critical, because we found it that sometimes politicians and others may not understand why we continue providing services to our key population. So you engage them, tell them the reasons why we need to provide services through our facilities and why the peers have to be at the facilities. Next slide. This program has faced challenges, including space at facilities. Some of the facilities these are government facilities. We may not have space. Sometimes we've got resources and put up temporary structures where people can come and access services. Then resource constraints has been a gap. Resources have not been there. We've mapped many facilities, and we've not established KP programming in all our facilities that provide services, and yet KPs are over. Then coordination is still a gap, and basically from a national, regional, and district. I've talked about space, and currently we are facing challenges of our KP data. Our data was being collected through our KP tracker, not the DHIS2. And now with the cut in funding, the KP tracker may not be able to continue. We need to host it into our national DHIS2 system. You need to have resources, because when staffs are going to do outreaches, you need to provide them with resources, train, to empower communities. You need to put up, you need to have space at the facilities. Then you need to have a budget for communication, for coordination, and then commodities, especially the testing kits. Next slide. If key lessons learned, we've had good leadership, because this is hosted within the government, and that is mainly through Ministry of Health and Uganda AIDS Commission. Engagement of stakeholders is very critical. I've talked about it. Then providing a standard package and having a timetable. If you say monthly, you fulfill it during your outreaches. Then follow up during service provision. Next slide. Thank you.
Thank you so much, Uganda. Do you have a community part of that, McLean? Because McLean
I don't know whether McLean is on.
Okay.
If she's not available, then that is it for Uganda. Thank you.
Okay. Thank you so much, Uganda, for the highlights of what that integration, the KP integration mean in the public health facilities. So we have seen a lot, and which actually is very important for the other countries who has not been able to integrate until now. So we have seen the principles, we have seen to the mapping process of where do we put the facilities, that was of critical importance, which services are we providing in those, identify the light facility capacity strengthening and all the challenges. We haven't seen how did you mitigate that though. So thank you so much for the presentation. So for the next 9 minutes, rather 8, if you have any question for Uganda, kindly ask, or you can write in the chat box so they can address this. Uganda team, please, if you be able to read on the chat box if people actually address their question there. And if you have any question, kindly you can raise your hand and unmute and ask your question.
Okay, thank you so much. Thank you, Dr. Margaret. Thank you for the team and the Uganda presentations. I really enjoy. My name is Deng Dominic from South Sudan. I work for Ministry of Health. I'm the focal person for key population in the Ministry of Health. I really enjoy the presentation. As South Sudan, you know, when it comes to KP programming, South Sudan is learning from zero level. I can say it from zero level because we were keenly focusing on the partner, which is paper, implementing the key population in South Sudan. And then the partial of it was being implemented by the Global Fund, whereby they tackles the part of the KP programming. So in terms of the bringing the national reprogramming together as a national KP programming was really hard for us. So the question I want to ask is, how do you manage the drop-in center, which is, the DIC, in your community scene, because you have been supported by the partner when your DIC was working now? How do you feel it currently? Because one of the things that facing us, basically with our KP, because we are not doing a facility base, which we use the facility staff, no longer any community, because there are no partners supporting. So how do we continue supporting the IDC sites that are in the community? That is one. Two, how do you do your reporting? Is it through the facilities or through the community into the DHIS2? Are the DHIS2 distributed in the users to all the communities, including the facilities? Or how do we channel your report into the system? So those were the two questions that I want to ask. Thank you.
Thank you so much, South Sudan. I wish if we could correct some other questions so they can respond them correctly. Parinita, I'm seeing your hand up.
Yes, thank you so much, Dr. Kakashi, and thank you, Gerald. I think it was a very, very interesting presentation and much needed one at this time. I'm just adding to Deng's question as to, because I saw that the facilities also have peer educators. So how do you hire these peer educators? Does the facility directly hire these peer educators, or are an implementing partner supporting you and deputing these peer educators to the facility? And when the funding closes or funding reduces, then what happens to those peer educators? So I just wanted to check about the community outreach linked to this facility. Thank you.
Yeah. Thank you.
Sorry.
Can I respond?
Uganda, can you take the questions because we have just a few minutes? Any other last question, if there is any? So also there is a question, I think, in the chat box. So if there is none, we can allow Uganda to go ahead and respond to the questions we asked.
Yes, thank you for those questions. Now, the DIC guidelines that I showed you those guidelines emphasized that each of these community DICs have to be linked to a public facility. Now, it was the responsibility of that public facility extend services to the community DIC. And answering the other question of the reporting, so this means that the reporting of whatever work was being done in the community DIC was reported through the facility DIC. Basically, because the facility DIC was extending and providing services and responsible for the commodities which were being supplied to the community DIC. So this process was easy, or is a bit easy, although as a country, we still face challenges because we have some community DICs that have closed and some are still operational because some were funded by different funders, not basically PEPFAR, because for us, the community DICs were mainly funded by PEPFAR, not Global Fund. But we had some other funders. And in some areas where PEPFAR is still operational, we still have those community DICs. But we see that challenge is still there. But the beauty is that most of these community DICs were linked to a facility. So there is a continuity of services. How do you, hiring peer educators? Yes, it is still a challenge. But the good thing, some of them who are linked to the facility, some of them, since now they already trained and they work within the facility, the issue of sustainability is there. Some have continued to volunteer. And when a program comes in and they have a few resources, these peers benefit. They no longer get a monthly stipend, but they are paid on availability of an activity. And since they are linked to the facility, they are basically working as volunteers.
Thank you so
But
much.
it is a challenge.
Okay. Thank you so much, Uganda. I think you addressed some of the questions which are very critical. If there's any last question as we're winding up, we had like, so the question, I'm not sure. So on funding cut, and now they were taking them as volunteers, and this looks like very challenging because probably they may not volunteer for longer period as they usually get some funding from the implementing partner. I would just want to ask just question to clarify. If you are told to categorize the percent of the effect you think it's affected the funding, the KP programming in the facility, will you how range will you put 10%, 20, 90, 60, 50? What's the range of effect of those programs at the facility level?
I think at the facility level, it is more than 50%. It has been affected more than 50% because in the region we had the USAID and the CDC, and basically where we had the USAID, we are no longer doing much KP programming, apart from if KPs walk into the facilities, they can receive the services. So that's why I can say the effect is more than 50%. And when it also comes to the commodities currently, like the HIV self-testing kits, like PrEP, we are still having challenges with those. So the effect is more than 50%. I would say around 60% effect.
Thank you so much, Uganda. And we appreciate for those who asked questions in terms of how the reporting looks like. They said we have the mother facility, which actually takes in the report from the community. they had highlighted some very key issues, including capacity buildings, including identify the right facilities and all that. So if there is no other questions, kindly, for those who are joining in now, please, if you could register and on the chat box, your name, your organization, your country, it will be much appreciated. So thank you so much, Uganda team, for the presentation for what you have presented. I think we have learned a lot. We'll hear from the countries, the takeaways from other countries, which I think is something to learn, and we appreciate that. So we go for Malawi. I think Malawi team is ready. Maria Nguru will be presenting from Malawi, and Danka Kamba. So over to you, be having the 10 minutes from your end for the presentations before we go for the breakout sessions. Malawi, for those who are not registered, please remember to register on the chat box.
Thank you so much. Good morning, good afternoon, everyone. So I'll be presenting on behalf of Dominic. So as the previous presenters, the situation for Malawi is the same. Key populations still continue facing barriers to accessing HIV services. And the prevalences are still also high when you compare with the general population, despite the different interventions being done. And due to that, as a country, we're promoting diverse approaches to achieve equitable and also client-centered care, so that we provide specific to the community members. And also these are all aligned in our country documents, the National Strategic Plan, which have also stipulated the minimum service package for key populations specific to MSM, transgender, people who use and inject drugs, just to mention a few. Next slide. So, yeah, so as Malawi, as I indicated, we also using different or a number of approaches to providing services. We use outreach services, and these are delivered at hotspot level with the use of peer educators who do the planning, looking at doing the risk mapping for each hotspot, and then they support in the what service should be provided at each service delivery point. And these are also supported with different donors, i.e. DREAMS and others. And also we use the drop-in centers in also providing the services. And Malawi was operating in 6 districts, which had established 16 drop-in centers, and with an average of 20 services being provided in a day. And they were also supporting ART cohorts. And of these, 55% of clinical services were being done at DIC. So you name them: the HIV testing, STI screening and treatment, ART, viral sample collection, and also research explaining to client. So there are also the services are also being provided through the KP-friendly public facilities, and they are also supported by, some are supported by the drop-in centers, which also support the public facilities. And in these KP facilities, healthcare workers were also trained in KP-sensitive and affirmative services. And also refills are also done for services that are not provided, i.e. at DIC or outreach. They're also referred to these public facilities, like services like viral load monitoring, which mostly depends on the mother facility to support with the processing of the viral load. Next slide. Yeah, so just to give a picture of the program support. So most of these programs dependent, or we are dependent on donor support. In the, like for Global Fund, I supporting 12 districts, and these were non-PEPFAR, we call them non-PEPFAR districts. And the 14 of these, that's where PEPFAR was providing the support, which are the high burden districts. So those with at risk lower are being supported by Global Fund. And also government contribution has been supporting with the health care workers and also infrastructure, and at some point logistics, to make sure that the outreach activities and other activities are provided. However, the gap that I can quickly mention up is we have 3 districts that were not supported either by Global Fund or PEPFAR, and these Chitipa, Lumpi, and Koma. Of course, these are low burden districts. However, with some program data, we have seen that there are some key populations that are also in these districts. Hence, the need for still to support these districts, like female sex workers, that are also present in these 3 districts. Next slide. So how has the country tried to integrate and sustain the gains or the program in trying to provide the key services to key populations? So Malawi has utilized the technical working groups, and that's where most of the discussions have been done to make sure that capacity building for government structures is done. And the key actions from these meetings has been training of public as well as private staff. And as a country, this was already started some time back, but moving forward, the country wants to intensify and train more service providers from the public facility as well as private facility, and especially those that are surrounding in the districts where they're drop-in centers, so that clients continue to access the services. However, NAC has also supported the non-IP districts, like the 3 I mentioned, so that the key populations that should continue to access the services in these 3 districts with at least a minimum service package. And also there have been referral systems between providers and the key populations, CSOs. So that kind of, the referral systems have also tried to strengthen the sustainability in terms of the populations continuing to access services in case of the donor-supported IPs move out, and also the closure of the DICs. And also there have been dedicated key population service delivery points, which were also opened in some districts. So to make sure that the deliberate efforts are made so that key populations continue to access services in such a district. And also the government has come forward to support outreach activities, thereby giving a learning platform for the government supported facilities to learn from the existing donor supports that are still in this district. So that kind of the platform has also supported the key populations, and moving forward, these will be strengthened so that it helps to clear the gap that exists. Next slide. Yeah, so key achievements that we can quickly point out is the trained government providers in KP-friendly services. Yes, this is not much, but a number of trainings have been done to make sure that we increase the coverage in the public facilities, and also expansion of access to all the districts. We want to make sure that all the districts have got the KP-friendly sites available. Hence, they need to train more, would continue training more service providers, especially from public and private sectors. There's been also a stronger referrals between IPs and public facility we have seen that, and in some districts where the drop-in centers have been closed, clients have already been transferred out to the public facilities, others to private facilities, though the process is still going on, but we have seen that achievement there. And also district KB subgroups and coordinators appointed. So currently, almost all the countries in Malawi have what we call the KP coordinators available, so that they help and support to track services and access of services for key populations in those districts, and provide a platform where people can come together, plan, and move forward. And also enhanced data systems. So all the district health or public service provision sites have been linked to the district health office, where each partner is supposed to report data to the district health office, so that the data can be tracked. And also just the like for the Global Fund districts, they have also been encouraged to use the key populations database, so that we keep tracking all the services and the data for the key populations. Thank you. Next slide. However, there are still some.
Wind up the whole presentation.
Yeah, so however, there have been also challenges that have been affecting the implementation, especially those from the sites that were being supported by the USAID. We noted that gap, and there is need to quickly fill that gap to make sure that key populations continue to access services, and also infrastructure gaps for key populations in public facilities, though discussions are still on the way to say how best do we structure or come up with a space so that key populations should continue accessing services. There have also been lack of pre-service KP training, which is also a big gap that is affecting service uptake, and also limited outreach funding, so that the country continues to provide outreach activities, as most of the community members access services, PrEP or LRT, through the community services. Next slide. Yeah, so I'll let Danka continue from here. Thank you.
Thank you, Maria. Hello, everybody. And I think most of the things have been really put up through by Maria, and I'm just going to finalize it, just add a little bit more concrete to it. The positive outcomes that we have seen, first and foremost, is the access, or the improved access in the non-IP areas, where we identified the needs that, there's some kind of reduced stigma and discrimination, but also there's a need to kind of train providers in private clinics, because mostly I think we've been concentrating on the mainstream providers in the health centers. So I think there's a need to also diversify and also engage the private clinics, but also rolling out the social contracting that is targeting the KP-led organizations to offer services to the community members. I think this would also be ideal to that. However, I must also say that the initiative actually brought out, the increased visibility of our KP issues, where, as KP organizations, we are able to sit in the national conversations. And I think it's also thanks to SSLN on the advocacy part of it, but also within the KP-led organizations, there's a kind of stronger collaboration amongst our organizations, where we have greater unity and our voices of purpose. Still, again, I think we probably still do need the KP-led organizations, there's a lot, like Maria said already, the shortages in the funding. So there's a need to have, resources for continuity. But also a need for the continued, the direct funding mechanisms for the KP-led organizations, but also need for the ongoing support in areas as documentation, and I think Maria mentioned something about data, but also in M&E, but also proposal writing, but as well as the digital advocacy. Thank you so much, and over.
Thank you so much, Malawi. We appreciate for the highlights we had. And one thing I just to highlight the key issues that we think the community, I just to put in on the concrete winding up of the presentation from Malawi. Here from the community is of critical importance. And 2 things, 3, 4, I picked them up. So I was wondering wow, that is nice hearing from the Malawi team that we have the KP coordinator until to the regions and council level. That was impressive because most of the country couldn't pick that KP coordinators, even to be called KP coordinators from the region level to council level is a bit of a challenge. So thank you so much, Malawi, though the challenges which has been highlighted and the mitigations which has been put in place, the outcomes and the improvement we have seen. So thank you so much for that. So over to you. We have almost 6 minutes for the questions before we go for the any question from the audience you have any, please write on the chat box for Malawi. Any question for Malawi? So taking that we understand correctly, and that was a clear presentation. So probably we'll hear takeaways from the countries if we don't have any questions. But if at any point you have a question, kindly put it on the chat box. If we have moved from other sessions, for the Malawi team, just have a look on the chat box if we have any question, because I haven't seen any question on hand up for any question from any of the countries. So thank you so much again for all the country who has been presented here. Now we'll have few minutes, 30 minutes for the breakout sessions. So on the breakout session, we'll be having 3 sessions or 3 rooms. So you will choose where you are comfortable with. And I know that the SSLN team will be in every breakout session. So just make sure that we have notes. Remember, we'll be having, after that breakout session, we'll need to hear from the chair of that session to ensure us we have a summary of what you have discussed for 1 to 2 minutes. So you will summarize everything around after discussion. So we have almost 30 minutes for sessions in the breakout sessions. So can this session be brought so people can select where they choose to be? I hope it will be shown here.
From our group, perspective of subnational government on integrating key population services into public health facilities. We looked at the opportunities and we gave our response that the opportunities we have is that we already have human resources existing in the public health facilities. We have infrastructure that is health facilities, and we also have policies. It's just a matter of implementation. We also agree that we have commodities. Governments procure commodities for everyone. So we have commodities like condoms, test kits, and all the rest. And then we also have systems in place to capture data. We also say we also have domestic resourcing, and then we have abilities of national and subnational government to have interdepartmental collaborations, and then also flex. So one of the opportunities we have is that we can have flexibility of donors. Like, for example, with the stop work order, we could have Global Fund, for example, come in and cover some areas. So those were the opportunities. The concerns we have was that there's inadequate training of health workers in KP programming that is linked to issues of stigma and discrimination. We also had concern of trained health workers being transferred frequently. Then also limited space dedicated to KP service delivery in these public health facilities, inadequate commodities. For example, we noted that KPs need to do HIV testing more frequently, but maybe the public health facility had only planned for a number of commodities. Then inadequate stakeholder engagement also impacted funding and the policy environment, where there is criminalization of some of the key population activities. Then bureaucracy in government systems, like it has taken long for the long-acting PrEPs to be approved. Inadequate resources for services, for example, outreaches, now that funding has been cut, inadequate resources to carry out these activities. Then one of our concerns was also the cultural norms that more prohibits some services for key populations. And then also data issues. We don't have enough tools to capture data for KP data. We have also parallel systems. Sometimes data for KP is not captured. Then under recommendations, we recommended that we should strengthen the capacity of the human resources, both the health workers and the peers, and also include KB service delivery trainings into other education system, as well as in-service training. We should increase domestic funding to be able to provide, to integrate these KP services into public health facilities. We should continue stakeholder engagement at both national and subnational levels to address funding. Then we should also sensitize the community and provide awareness, including for community leaders, cultural leaders, religious leaders. Then we should also, we also agreed that KP reporting should also be integrated into the national systems like the DHIS2 system, and then to do community-led monitoring. Back to you, Madam Missy, or to the chair. So this is what we discussed in our group. Thank you.
Thank you so much for the subnational government group on the integrated KP service perspective. So I wish we could hear from all the groups. And
I have one addition. I don't know.
You have one addition? Okay.
Yes, my addition, because the time just dictates us and cut off before we wind up. One addition I want to add is, as a recommendation, is a KP, national KP programming. You know, is one of the challenges we always have to have a national KP programming, which inform us for decision making. So that was one of the addition that I need to add in the recommendation. Thank you.
Thank you so much, Deng. We appreciate that. And we understand the situation in South Sudan. Okay, let's hear from the second group on the KP networks. What's the perspective? Kindly, let's be brief. What are the opportunities concerned? Just in summary. Thank you.
Yes, Victoria, kindly give us a summary of our discussions. Victoria Natoni, please.
Is she available?
Victoria? Okay, if not Victoria, then I would have to refer back to our chair in the group, Danka.
All right, thank you very much. So I'll quickly just run through what we had discussed in our group. So on the opportunities, we looked at 2 opportunities this far. We looked at the existing working relationship with the AIDS councils or AIDS commissions in our respective countries, but also a Minister of Health, to access the services, but also looking at our presence of KP guidelines and the policies. We could refer back to what our national strategic plans are talking about and other documents that do mention about KP, and use that as leverage or use that as evidence to argue or maybe to help in the mainstreaming efforts. However, we also had some concerns where in most of our countries, we still have most of our laws still criminalize most of the KP work, be it sex work or maybe drug use or sexual orientation or gender identity. We looked at that as a concern that might, affect access to services. But also lack of information, as much as we would like to mainstream, but our doctors, nurses, or healthcare providers in our government hospitals knowledgeable about, do they have information about KP specific health needs or our health risks and vulnerabilities? I think that one came up as a concern. But also, again, I think I mentioned about the laws and discrimination, but also untrained peer educators in sites and lack of programming in high burden district regions, as for some specific countries which, voiced out such. On the recommendations, there's a need for more sensitization for our healthcare providers or our healthcare workers on stigma reduction, but also offering quality health services, but also having a meaningful engagement with the KP community in planning, implementing, but also reporting. Maybe most of the times our populations are just, used at some point. We don't really finish the whole circle. So we'd like to see meaningful, meaning that we engage in all angles, in all other stages, from planning to execution. Another one is also the need to send funds for the DICs to continue programming, because now most of the DICs have been US government funded, which means most of the work have stalled. And now we really need to have funds which would make sure that the DICs continue their services. Empowering also KPs through the networks, CSOs, but also collaborations with government to understand mandates that support them. So basically, I think this is what the conversation that we had in our group. Thank you, and over.
Thank you so much for the KP Network team. Summary from the implementing partner. Kindly summarize what are the key issues. We appreciate to summarize, because we need to hear from the country takeaways. Implementing partner group. Who is?
So anyone from our team, the IPs?
Yes, I'm here, Victoria.
For the implementing partner. Yes.
Yes, I am among the implementing partners. Victoria from South Sudan.
Yes, guys, can you hear the summary of your groups? What has been transpired? Who is presenting from the implementing partner group?
Everyone, this is Elizabeth from Uganda, working with Dr. Pasquin. Yes, so from implementing partners, different countries brought in their opportunities, concerns, and recommendations. From South Sudan, there was adoption of drop-in centers to ensure service continuity and address stigma. Then they were also looking at an opportunity of leveraging on existing community volunteers or community health workers to support integration of KP services during the Global Fund PEPFAR transitions. Under Malawi, the KP-led organizations were driving community mobilization, and then we're also using point of contact systems to maintain continuity of services. Then we're also looking at the opportunity of availability of the Global Fund G7 to support advocacy and service delivery. The challenges shared, the shared challenges that can drive cross-country advocacy for improved KP access. Under Uganda, we're looking at integration of KP services, for example, reproductive health services, and other funding streams to include HIV prevention, care, and treatment. And then also the peer educator model supporting community mobilization and linkage to services. Regarding concerns, so KP-led organizations, many have closed down, and they are citing new rates of HIV infections with limited reach to KPs in their hotspots. Then another concern is coordination of IPs that were under PEPFAR to take up KP service delivery, which is proving to be challenging. Government support and intensified efforts in prevention activities, for example, condom use or PrEP, that have been scaled down of late. Then there were existing challenges in the point of contact model amidst the stop work order shifts that the country experiences. Then KPs still struggle with stigma and discrimination, especially with treatment at public health facilities. Then there's need for capacity building and training of healthcare workers on handling KP-related issues. So under recommendations, saying that if the DICs are not at the community level, they can be made available at public health facilities. Then there's need for clarity on coordination for the country to address KP service delivery for PEPFAR-supported facilities and as well as interventions. There's need to reprioritize high-burden districts and ensure there is a balance between the high and low volume geographies. Then the KP tracker database should thinking around cascade across the districts in Malawi. The quick assessment of service access in areas where DICs have closed, and training aimed at client-centered services. Then the government is also to recognize and support efforts and gains contributed by implementing partners so that this would help in the transition process. Then integration of the volunteers into KP program calls for mentorship to effectively support KP program implementation in South Sudan. Then finally, there is need for capacity building and training for health workers as we rethink the integration. That was from the implementing partners. Thank you. Back to you.
Thank you so much for all the thought was put on this and discussion. I hope every country has just got something new out of it, and you have learned a lot from different perspectives. Everyone has something to learn from different countries. So I just want to appreciate everyone who participated. For 2 minutes, 3, we need to hear the takeaways from countries which have joined. What have you, what is your takeaway as a country? What do you think you can go and just work on something actually we have learned from this, from the sessions, from the discussions from other people? So kindly just summarize what you think you are taking. We'll hear from Kenya. Let's start from Kenya. Kenya is your floor just for the minutes. What is your takeaway? Kenya, please, as Tanzania, today I'm not a Tanzanian, kindly note that the Tanzanian team prepared themselves, and we have South Sudan and last Burundi just for a few minutes. Burundi will be our last because joining the meeting. Kenya, please.
I had seen Dr. Ndolo. This is John Bao, KP lead NASCOP. But as well, I can go in, maybe Dr. can add.
Please.
One on HRH.
Yeah.
Sorry, on HRH, one of the key recommendations we've taken and we've noted earlier was a gap as a country is the capacity building of healthcare workers on KP stigma-free services, just to ensure that those healthcare workers who are working in diocese are we capacity build the healthcare workers who are government, so that in the event that we don't have support for HRH, they're able to pick up and continue. Another key thing we've taken, I think that is on HRH, as well as peer educators, working on models that are long and sustainable, ensuring that where the government can be able to absorb them, those who are experienced and who used to work with CSOs, they are absorbed and we are able to integrate well, and then the government system, unlike what has been there before. On working with implementing partners, the issue of in-country local funding sourcing, liaising with the government, and I mean a good strong collaboration within the government and the local partners to lobby for funds, implementing partners, sorry, to lobby for funds in country that are available to continue sustaining and funding KP programming. I think on the other thing is on CSOs, continuously engaging the CSOs, ensuring that they are factored in integration, and seeing areas as the funding is going away, where the government is able to support the CSOs to come in and support KP programming. I think those are the key points, so that we don't take all the time for the others. I'll be happy to listen if Dr. Nolo adds, but we appreciate the opportunity to have gotten such.
Thank you so much, John, for the what's a takeaway. That is very critical on that aspect. So let's take it from Tanzania. Dr. Zay was supposed to join in, and I think Abdul or Serafina from MOH, kindly.
Okay, thank you, Dr. Margaret. As all African countries, we share the common foe. We have learned a lot from this discussion, but mainly we have grabbed the stabilization and the use of SLM to solve advocacy issues, especially A-level leaders, community leaders like traditional leaders and region leaders. So we have taken that to make sure that we stabilize ours in our nation. But also the issue of advocacy when it comes to issue of bureaucracy, that also seems to be an issue in our country. So men have contributed on that, and we are taking that into action to make sure that we stabilize the KP program in our country. In nutshell, I would say that. Maybe if Dr. Seraphine has something to add. Thank you.
Okay, thank you so much to Tanzania for those takeaways and action points to work on. Let's hear from South Sudan. Gabriel Atilo. Gabriel, over to you. Gabriel. South Sudan. Hello, South Sudan.
Gabriel is not online.
So who kindly can we hear from South Sudan? Just a takeaway. What is your takeaway? In a nutshell.
Okay. Let me help as Gabriel is away. Actually, on my side, in the side of South Sudan, we really appreciate this learning, and such a learning will support the program, though we don't have enough funding that can help the KP in most of the country. Like in South Sudan, since the paper withdraw from KP activities, the KP has been down, and to get the MSW to the facilities has been a challenge for us, and it is because there was no integration services before. though the treatment was within the facilities, but the actually implementation was like a separate community and just linked. So there was a gap, and up to that gap is affecting the services now. So I learned a lot, and we learn a lot from these integrations, which is a key thing that we are looking at. The other thing I also learned is about the issues of stakeholders integration, stakeholders engagement in other countries. The leadership of the government are on top of this priority, and for us to achieve this, it should be the leaders to take up and pick where we are, including the domestic funding. How long are we supporting depending on donors? Yet Africa is rich and we can generate a lot of resources that we have. Only that we need to prioritize where do we want to put our resources. That was one of the things that I learned a lot. And also I learned a lot inside, especially in Uganda. And this whereby I can say it, learning engagement from nearest facilities is a key thing. At least like South Sudan is a new country which need to learn a lot. So it is opportunity for us to learn from our neighbors, especially in the East Africa where we belong. We need to learn a lot from East Africa, and at least let's continue having engagement. Though we don't have a funding now that can bring us face-to-face class, but we can learn through virtual meeting like this, and we are able to pick up. Otherwise, I will appreciate if the source learning network can continue supporting the team using the virtuals for the time being. We are able to learn and we're able to pick up in some of the areas. Otherwise, thank you so much. Thank you, Dr. Margaret, and the team and the leadership of the South Learning Network. Back to you.
Thank you so much, Dominic, and the South Sudan team. We appreciate that the takeaway, and a lot of things to work on. Let's hear from Burundi. Burundi is our guest today. Burundi, you have 2 minutes. Just can we hear from you? What is your takeaway after hearing all the discussions? Burundi. Burundi, as Burundi preparing themselves, kindly, you have seen the poll on the, kindly fill in that poll now. Is everyone seeing that? Please just fill in. It's very important for us as we continue learning. Burundi, is Burundi still available? So let me read one comment from the chat from Fatima as we're winding up. Malawi has been supporting an IP that implement a public facility KP-friendly integrated service without creating a special KP service delivery service point in the facility, and it is working well. No need to extra staff. Yeah. So Fatima, thank you so much for this. Actually, I've seen this in Tanzania too, because we don't have a special place like when you go there, it's just for KP. It's just a friendly services. And we appreciate this actually putting this on the chat box. A lot of people can learn. So as we're winding up, there are key issues I wish to talk about. So we appreciate Uganda and Malawi for all the presentation you've made. Countries.
Can I add something?
Yes.
Or is everything done?
Hello?
Yeah, I was just going to add one of the action points from South Sudan.
Okay, South Sudan.
Or are we okay? Yeah. Yeah. I was just going to talk about that the government will collaborate with the partners in terms of mobilizing the resources, since we really have a gap in terms of activities has stopped in terms of the KP population. And we really look on how to, fill the gap of making sure that we're really able to mobilize the resources and also work together with the CSO. So that's what I wanted to add. Otherwise, thank you so much. And we have really learned a lot, and we wish to always attend the learning sessions. Thank you.
Thank you so much, Amioka and the South Sudan team for that. So as we're winding up, I think they have filled the poll, but three things to take note on. Do we need other staffs, like we need a lot of people beside what we have already in the facility? Do we need that? That's the first thing I've learned. Do we need training, the usual training, putting all people together in the room with this financial crisis? Or do we need to think, how can we facilitate training in a different modality to make sure the building capacity is ongoing? As an African continent, we are looking at everything around with all the funding cut. Do we need all the traditional training, or do we need to think outside the box as we sustain the KP program in our countries? Also, in terms of the data issue, do we need different model of correcting data from that specifically for only KP, or we can integrate in our own system? That now depending on the context as all the country presented. Remember your context and make sure this service is needed by these people. Again, thank you so much for the SSLN team for making this possible, for the country who are presented Uganda and Malawi, and all the country attended, including Burundi, who has been dropped but was in the meeting. So we appreciate Tanzania and Kenya and South Sudan for attending this, very important, and for contributing, and we have learned a lot from this session. And thank you for accepting me as a chair for today. I was not in Tanzania, not in Kenya, not everyone. I was just a chair, couldn't even ask those questions. So I appreciate for the opportunity and for the opportunity to chair all the team. Thank you so much, all of you. I think you have felt the poll. If the SSLN can confirm that, if you have done that.
Yes.
So, okay, wish you all the best. See you next time when we have another link and session. Bye.